Right. So I'm going to give you the algorithm which is applicable to many centers in Asia Pacific. And we need to have ideal algorithms, and we have to have algorithms for vast number of centers across Asia Pacific, which therefore do complex PCIs or have been forced to do complex PCI because they're the frontline centers in tier two and smaller cities, and yet face with heavily calcified lesions, which land up both as ACS or worsening angina. Now we know that angiography is the baseline for detection of coronary calcium and is a part of the syntax score calculation, but it has low sensitivity, but is highly specific. What does that mean? While we grade calcium on angiography as mild, moderate, severe, when calcium is seen on angiogram, it represents greater volume of calcium. It represents at least two quadrants of calcium. It has higher chances of underexpansion. And also, of course, angiography helps in tortuosity, angulations, procedural planning, hardware, etc. So let's not leave angiography for assessment of calcium out of the way, but understand calcium seen on angiogram means that you're starting off with a problem. Even mild calcium can take you by surprise, though moderate and severe calcium will take you by surprise, and therefore you should be wary of that. Of course, we realized over the period of time that whether ACS or non-ACS, filling defects in calcified vessels are quite likely to be nodules rather than just thrombus. And I think that is important when you see calcified vessels and predict and therefore prepare for the fact that these could be very difficult lesions. And I'm just on the first three slides talking about angiograms. And let's assume that you only have angiograms. And I love the C4 algorithm. Recently came out, the C4 came out with this algorithm, which says if you are, and by the way, only if imaging is not available. We have to emphasize that imaging is vital for treating heavily or severely complex calcified lesions. And you shouldn't do any complex calcified lesions if you don't know the tools or can't image. But if you're faced with such a situation, these are the few important points to understand. That optimal intervention management of severely calcified lesions on if angiography alone is available to you, the most important is a balloon test. What does that mean? When you actually break a calcified lesion, it has to be an optimal size, non-compliant balloon inflated to 18 to 20 atmospheres, and the balloon seen in two orthogonal projections to show there is no indentation of the balloon and that the lesion is open in two orthogonal projections. Also, that is the only time one implants a stent, and if a stent is implanted, liberal use of stent enhancement to diagnose full expansion and again in orthogonal projections becomes very important. And the stented segment of the vessel should look larger than the vessel's normal vessel on either side. Now, if there is a residual stenosis, it has to be only in one projection only. You do not chase it to beyond a particular point because the balloon is expanding on the other side. But residual stenosis at two projections is a bad news, and that's under expansion. So that's the basis. But one needs to understand the various tools that if you do fall in the situation of under expansion, how do you get out of it? But do not fall in the situation under expansion, even on angiogram, because you just need to be sure of your balloon test prior to stent implantation. But that balloon test is important even if you have imaging, and I'll just come to that. We know and understand, first understand the scoring systems of IVUS and OCT. We have to understand that these scoring systems are valuable, and I certainly use these scoring systems in my own practice. But the endpoint is not circular lumen, by the way. We have eccentric calcium, we have nodular calcium. If we keep chasing this with balloons, we will have perforation. In situations where you have an indentation and under expansion in one view, which is going to be quite clearly many patients who have eccentric or nodular calcium, the final MSA is at imaging the final endpoint, which is either MSAs greater than 5.5 millimeter square, and I say for a mid vessel greater than 6 millimeter square, I say for osteoproximal greater than 7.5 to 8 millimeter square. For proximal LAD, it has to be greater than 7 millimeter square. And if I were to say OCT, it's greater than 4.5 millimeter square or greater than 80% expansion. You will never get to 90% expansion. You'll only get that to nearly 40% of your patients and never to 80% of your patients. Well, optimal size balloon inflation in two orthogonal projections. You can see have severely calcified lesions. You have nodular calcium, but all the calcium score is at 1 and 2, and greater than IVUS score greater than 2 predicts under expansion. Well, this is a situation where I go in with a non-compliant balloon, 20 atmospheres, 3.5, two orthogonal projections shows me full expansion of the balloon. You can see extensive calcification here. Stented followed by high pressure implantation. You can see that the vessel is larger than compared to the vessel normal vasculature on both sides. Of course, this was IVUS guided, but this is just to show you that if you did not have IVUS, this is the sort of results that you want to achieve. And of course, the lumens were greater than 8 and 9 all over. This is an illustrative case which will take me to my last algorithm, which I have to show you, the imaging algorithm. If you had imaging, how do you actually take it forwards? And this is what looks like a discrete. I mean, that is like a Fellow's lesion, a discrete proximal LAD. But if you notice very carefully, you have some calcium just noticeable, even so during vessel movement. And this, so obviously, when I see calcium, and it's even if it's focal, if it's in two orthogonal projections, and I can see it very clearly, I do imaging, and you see, this is a gradation, OCT grade scoring 4. Thick calcium, greater than 5 millimeters, goes deep in, and has all the features of a bad, severely calcified stenosis. So one takes an IVL, and at 40 pulses, you can see that the balloon opens beautifully, and I've done the lesion. So in this epicranial projection, I go in and do OCT analysis. I see lots of fractures, and I'm convinced that I will get a good stent expansion. And so therefore, I proceed to stent, and I've therefore put in a stent, and you can see how beautiful and enlarged this vessel is at that particular point. I go to optimize this in ariocaudal projection, and look at this. I've got a residual stenosis. I've done the biggest mistake. I did not look, despite imaging, which showed me fracture, I did not look at the expansion in two orthogonal projections. I have an underexpanded stent. I deliver my remaining 80 pulses within the 40 pulses within the stent. I still can't get it open. I then go in with a ultra high pressure balloon at 35. Then I do an imaging, and I see that what I've got is an elliptical lumen. I've got a small lumen. 3.8 is my analysis. I should be here nearly close to greater than 5 on OCT as MSA is concerned. I go up with an OPN at 40 atmospheres, and then after OCT, now I've enlarged the area, and I have a 5.16 at OCT as MSA, and now I'm satisfied, even though on the imaging, on angiogram, I have a residual stenosis. That's where imaging helps, and that was the final result. So that I had, the fractures were at the extreme ends of the calcium. The thickest part of the calcium was not opening. For me, MSAs matter. For just a word about extra high pressure OPN balloons, you always need to understand the vessel size by imaging before you start using these balloons. Here's a case where I did not use imaging. Well, I would use imaging in other vessels. You can see I'm doing it on Impella. And I was just rushed because I had two complications which I just handled. So I didn't look at the proximal LAD. There was an eccentric calcium. I did an IVL to that. And then I put in a stent, and I had a residual stenosis, which I chased with an OPN ultra high pressure balloon. And you can see on the left side that it is indented, and the right side it opens. I have a perforation, and I therefore seal that up with a covered stent. Again, emphasizing the fact that with ultra high pressure, understand your vessel size. So here's the algorithm. We've talked about mild to moderate calcification. Let me just tell you, for me, even with imaging, the balloon test for me is mandatory. I would also say that if I didn't have imaging, for a vessel less than 2.75 or less than 3, I would use rotational atherectomy as a plaque modification device, especially if it was severely calcified lesion. And greater than 3, I would use an IVL or a cutting balloon. But for that matter, I feel cutting balloons, scoring balloons are a poor man's tool for mild calcification and some moderate calcification. For severely and heavily calcified lesions, I do not find them any use in an armamentarium. But if we actually have the balloon, and then I'm going to end with this, balloon crosses, imaging catheter crosses. By the way, imaging catheter may not cross many lesions and yet a balloon would cross. So go, forget that statement that imaging doesn't cross, balloon won't cross. That's not true. Imaging is a poor catheter. It won't cross many lesions, but then you can predilate and do imaging. Intravascular imaging is important. If I see nodule, eccentric calcification, or a vessel size which is less than 2.75 or less, I would do rotor or orbital or OPN. But if I have thick calcium, deep scoring, greater than 3 millimeter vessel, I would do an IVL to that. I'm going to justify to you these are the best ways to be cost efficient rather than just get into a faffing around with multiple tools. And of course, after that, even with imaging, even if I've imaged it after calcium modification, I would do a balloon test in 2 orthogonal projections, then only put in a stent. If I see eccentricity, if I see it's not expanded, I would then use the next tool in my armamentarium. For example, if I've used rotor, then I will follow it up with an IVL to get the best balloon expansion prior to stenting. And of course, final imaging in these cases remains the gold standard for optimization. Optimization of these vessels is important to give the best long-term outcomes to our patients. So with these, I just have put into perspective 2 facets of the algorithm. One, where we don't have imaging, and where we have imaging. But also, I would say, please refer patients. Do not take up complex, severely calcified lesions without imaging. And you should learn to stop at a particular point, and you should learn to refer patients, because 50% of the patients I treat are failed at another center, calcified lesions are failed at another center. And unfortunately, that was because of lack of imaging, inability to cross, and inability to dilate a vessel or under-expanded stent. That should be a no-no. Learn to refer complex, severely calcified lesions. Thank you very much for your attention.
Thank you, sir, for your excellent presentation.